So I'm going to introduce Julie Porcelli, who is, she is at New York Presbyterian, Columbia Hospital, and she is the director of the ILD program over there, and again has been doing this for a couple of years maybe. And so I think we'll really have some great information to share with us. Thanks. And she's going to talk about comorbidities of IPF.
Okay, thank you for having me. I'm excited to present how to identify and manage the comorbid conditions in IPF. As we all know, we have many patients that present to us with pre-existing comorbid problems, but we also have many patients who develop these comorbid conditions as their disease progresses through the IPF journey. So who is the common profile of an IPF patient? It's usually a male, greater than the age of 50, and is a current or former smoker. And it's these three simple characteristics that predispose our patients to a lot of the comorbid conditions that we're going to discuss today. First one is lung cancer and emphysema. About 70 to 80% of IPF patients reports having a former or current smoking history. IPF patients then have a 5 times increased risk of developing lung cancer due to this history of smoking. About 30% of IPF patients also have concurrent emphysema. The concurrent emphysema does complicate the CAT scan picture, as a lot of times the emphysema overcomes the fibrotic process, making the fibrotic process not be diagnosed early enough. So we need to have a low suspicion for new lesions on CAT scan. These malignant cancerous lesions, for some reason, tend to start in the lower bases where there's extensive fibrosis or honeycombing. Again, complicates the diagnosis of cancer, but that misdiagnosis can be devastating for our patients in the long run. We need to do low-dose CAT scan screening for all former smokers that were not doing regular high-resolution CAT scan monitoring. And we need to also consider adding COPD treatment for any of our patients who do have a concurrent diagnosis of emphysema, and we use the consensus guidelines for that. Another very common comorbid condition is coronary artery disease, and that's defined as a greater than 50% stenosis of a major coronary vessel on heart catheterization. The prevalence ranges from 4 to 25% of all IPF patients. That makes IPF patients have a 3 times higher risk of experiencing acute coronary syndrome. So we need to be very vigilant in getting a cardiology referral for any patients who report ongoing angina or any coronary calcifications noted on high-resolution CAT scan. And these coronary calcifications noted on CAT scan have a very significant correlation to actual coronary artery disease with a heart cath. Thromboembolic disease. 2.7% of our IPF patients will develop a thromboembolic event sometime during their journey. That's a 2 times increased risk than non-IPF patients. So therefore, we need to have a low threshold for VQ scanning in patients with acute respiratory worsening. We need to do education on the risks of thromboembolic causes, signs, and symptoms so that our patients know when to alert us. Pulmonary hypertension is a mean pulmonary arterial pressure of greater than or equal to 25 millimeters of mercury, and it's diagnosed in 29 to 46% of IPF patients undergoing a right heart catheterization, usually in preparation for lung transplantation. So it's kind of an incidental finding in many patients. As clinicians, we need to have a high suspicion in any patients with dyspnea or oxygen desaturation out of proportion to pulmonary function, or those who have other clinical findings suggestive of right heart failure. We need to do diagnostic testing. Starts out with an echo, perhaps leads to a right heart catheterization. We need to really stress oxygen compliance as the primary treatment for pulmonary hypertension, non-pharmacologic treatment for pulmonary hypertension. And we need to do early referral and co-management with a pulmonary hypertension specialist. As we broach upon the fall and winter seasons, we need to be very vigilant of acute and chronic infections. Acute infection falls only second to acute exacerbation in the cause of rapid progression of our fibrosis in our IPF patients. The progression increases with age and also with the increased age of the immune system. We need to stress preventative vaccinations, pneumonia and influenza. We need to do patient education on self-protection, perhaps not being part of those large groups where they can be exposed to sick individuals, using hand sanitizers, perhaps even using a mask if they need to be in large groups of people where they may be exposed to any undue infection. And then we need to consider early antibiotic initiation when indicated for the signs of acute respiratory infections. As we all know, these infections can be devastating for our patients. Obstructive sleep apnea. It's an apnea-hypopnea index of greater than or equal to 15 events per hour. It may be present in 58 to 88% of IPF patients and is strongly associated with ischemic heart disease. Nocturnal hypoxemia strongly correlates with increased right ventricular systolic pressure or pulmonary hypertension and overall worsened survival rates. We need to send our patients for overnight oximetry testing. Anybody who comes to us with reports of increased daytime somnolence, sleep disturbances, we need to have a low bar for sending them to be tested to see if they have this hypoxia at nighttime. We then could do a formal referral to a sleep clinic and do polysomnography. And then we need to encourage compliance with CPAP if it is indicated. CPAP seems to be a challenge, much like the oxygen systems, and getting our patients to wear it consistently and be compliant. Chronic dry cough seems to be the #1 patient complaint that we don't really have a good solution to most of the time. A chronic cough is a cough lasting more than 8 weeks, and it mostly affects the patient's quality of life. They can no longer speak, do their jobs if it involves speaking, sleep at night. So our treatments are usually starting out with over-the-counter cough suppressants. We can always start there. We can add decongestants and antihistamines if we feel like postnasal drip, nasal congestion may be contributing to it. Benzonatate capsules, neuromodulators, and then if we need to, we have to be careful, but we can order cough syrup with narcotics. You just have to be careful of the respiratory depression in these patients who are already compromised. Gastroesophageal reflux. Prevalence may be as high as 30 to 50% of IPF patients have this diagnosed. And that actually may be an underestimate because a lot of our patients have what we call silent GERD, and they do not know that they even have that going on. We need to have and develop better screening tools. We need to send our patients to barium swallow testing or esophageal pH monitoring if we do suspect it. We need to educate our patients on lifestyle changes, such as elevating their head of bed, smaller meals, about 4 hours away from the time that they think they're going to go to bed at night. Perhaps getting rid of alcohol, spicy foods, things that would exacerbate it. We can order antacids, H2 receptor antagonists, and PPIs. And in the event nothing is working, there is a surgical option of fundoplication, which is appropriate for some of our patients to prevent the GERD. There's a lot of talk about deconditioning. It's the loss of muscle strength and endurance due to physical inactivity. And this is usually a result of the dyspnea and hypoxemia in our IPF patients. As she said, they're afraid to exercise, they're afraid to be short of breath, they're afraid of not feeling well. So what do? They tend to want to sit at home and isolate themselves. It is an important predictor of mortality in our patients. So as she stated, we need to encourage our patients to attend a good pulmonary rehab program. And along that line, we need to provide them with adequate oxygen delivery systems, which we also discussed earlier is a challenge for all of our patients. Pulmonary rehab usually has all those things in place, so the patients are able to go there and exercise to their capabilities. We're not going to fix the inside of their lungs, but to optimize their core, their breathing, how to use their oxygen, all of that's extremely important. And the depression and anxiety, 12 to 49% of patients with the IPF diagnosis code also had a diagnosis code of depression. It increases with the increasing duration of the disease and as the people get more and more debilitated, and it's a big impact on their quality of life. We need to encourage local or online support groups, and those are available everywhere. We need to encourage, once again, pulmonary rehab. It's a good social outlet, gets these patients out of their home, gets them to interact with people who have similar diseases, need similar equipment, and many times have good suggestions and ideas for our patients and how to cope with having to be oxygen dependent. And then there's always the potential role of antidepressant therapy that we need to consider in patients. So in conclusion, these comorbid conditions may pre-exist and many times develop anytime during the course of IPF treatment. Early identification and treatment does show to increase the overall quality of life and improve mortality rates. So it's really important as a team that we keep our eyes and ears open, listen to our patients, and co-manage or refer them when needed. And that's it. Thank you. Do not give me 8 minutes of questions. Yeah.
So I'm a social worker in Grand Rapids, Michigan. A lot of people are talking about anxiety and depression, which is awesome. But I haven't heard anything about which scale do you guys use? Do you guys use a certain, like CFQR or the GAD-7? Is there anything that you guys use as standardized testing for anxiety and depression?
There's a self-assessment that we found. Remember that? It's like a PHQ-9 for depression.
But with some, I made some modifications to it.
Okay.
Just kind of like we did with the exposure questionnaire. We
Okay.
sort of tried to take the best of what we saw, since we're not doing it for research purposes and worried about a validated tool. We tried to put it all together and do it to where it was user-friendly for our patient and got to what we need to know, because of course, our main thing is we need to know how to talk to the patient and how to refer them to the folks who are going to be, because we're not going to be in charge of that care. So that's what it is. It's like 3 different screening tools.
And is a good one. HADS is another good one.
Yeah, I can't remember now off the top of my head the names, but there were 3 different ones.
I was going to say that we also have developed like a questionnaire that has multiple different things on it, just to kind of decrease the burden of doing 17 different screening tools. So we do ask questions about depression and how they're feeling, but it is incorporated in something that we developed on our own at our institution.
I think it's important that we make sure we ask those kind of questions.
Yes.
But we need to do, in a clinical setting, you need to have a tool that is your go-to tool that makes sense. Especially if you use it longitudinally. A lot of times in clinical trials, we'll use these tools like the St. George's questionnaire, that it's difficult to score and make some kind of sense out of if you're not using it all the time. And it's a long, lengthy questionnaire for patients to fill out.
Yes.
So you want information, you want it now, and you want to be able to compare it to previous so that you know if your interventions are working. So it's, one-pager, few questions.
Well, you also have to be prepared to act on those answers. I mean, we've had a question of, do you have any suicidal ideation? And we've had probably in the 9 years that I've been at it, maybe 3 people check yes. And you show that to the physician and they're like, oh, wow, now what do we do? Well, now we're gonna have to make sure that the person's safe to go home, has adequate resources and referrals so that, we ask the question. So you have to make sure that you ask questions and you have things in place to take care of them.
for pre-transplant patients, we also use a CyPAT, which is not specifically geared. It's really more high-risk indicators, but certainly anxiety and depression are one of the psychosocial risk factors that we look at. And I can talk to you more about that if you want.
And I think if you could get a social worker as part of your team, we don't have one at Columbia because we've struggled with, do we have enough things for that one person to do with our program? So I kind of end up being a little bit of a mini social worker sometimes. But I think a social worker would be a great asset in those situations because these patients do need a lot of support from everybody around. So kudos.
You said you spend the majority of your time with CF, and then you kind of, so you wonder if a lot of people do that where they kind of carve out different pulmonary specialties.
Well, depression itself is just, these patients have to give up sometimes their job, the things that they enjoy, travel. It's certain mean you can't fly if you're on high levels of oxygen. It's challenging if you have tanks to go, travel too far as well. Although some of the companies will help do that. So you're asking these people to give a lot of these things up. It's no wonder that they're depressed. Yeah. Yes, a lot of loss.
I gotta think about. I think one thing that hasn't been mentioned is that, this isn't really a question, but is that we also need to utilize palliative medicine a little bit more.
Yes. That's a good
And then we
point.
also need to make sure when we bring that up to the patient. She gave me $5 for something. But I think when we mention it to the patient, we need to start talking about palliative medicine early on, so it's not something that, they refer like hospice palliative medicine, they think we're giving up. I do think probably everyone in this room, we just don't do a good job talking about palliative medicine to these patients. All right, that's $10.
I think that the comfort level of the clinicians and the patient, it's kind of hard, especially if you're meeting somebody for the first time and they're one of these people who came to us really late in the game, or you see everything progressing and kind of tumbling before your eyes. It's really hard to look at someone and say, glad to meet you. Can I talk with you about palliative care options? It's kind of, sometimes it's challenging. We've had to do it, unfortunately, but it's a good point, yes. Very important.
Two in the back there, I think. No problem.
I probably have a loud enough voice, it's okay. I think that every patient that comes in, you have to assume they have a degree of depression, that every patient has to be referred to palliative medicine, and it has to be part of your team, whether you're the only member of that team at that point, and that you assume that that is just part of everyday treatment, that this isn't something special. And if they know that that's how you're doing it, and that's part of the whole picture, that they accept it a lot better than, that maybe the fifth visit you say, oh, we should talk about palliative medicine. Like, why didn't you mention it to me before? So if you review it with them in the very beginning, that this is where we're going and this is what we can help with, that it's accepted as part of that whole course.
We actually, Kathy's going to talk a lot about palliative care. She said she'll give you $5 as well. But, we actually did. There you go. Now that would be great. But, we actually did a video in Pittsburgh with Kathy and their palliative care team. And, the whole point of that was really was very early, almost one of the first visits, is when that discussion was had. Like you said, rather than all of a sudden they're getting worse and it scares them, that they think it needs more aid. So,
This is a totally different topic now, but on the thromboembolic slide that you had mentioned for imaging a VQ scan as opposed to, typically we do CTAs. I wasn't sure if there was a reason why the VQ was noted in that particular, as opposed to like doing a CTA?
I think either one is acceptable.
Okay, so it wasn't
yes.
like there was something that was more appropriate about a VQ, because I think about chronic embolic events with VQ, but not,
Yes.
okay, so either
Yes.
one for an acute.
Yes.
Thank you.
Thank you.
We filled that.
I just had 8 minutes.